Good morning, everybody, and welcome to this session of the AMR Community of Practice. This is our second session for March, so we hope to have at least 2 sessions per month. So we're very happy to welcome you back for this session after the last successful session where we talked about external quality assurance. On this session, we're going to be talking about workforce development. So we know that in many countries, skilled professionals capable of generating quality AST laboratory results and interpreting AMR data, or even designing relevant and representative AMR surveillance protocols are required if we hope to have really solid AMR surveillance systems. However, we know also that in most of our countries, these professionals are scarce. And so ASLM is leading a consortium of partners and expert organizations under the Qualifying the Workforce for AMR Surveillance in Africa and Asia QWArS project, which is funded by the Fleming Fund, to support this, to build capacity within our workforce to be able to meet these requirements. So QWArS contributes to human resource strengthening and capacity building for AMR surveillance by the provision of microbiology and epidemiology training for AMR in the human, animal, and environmental health sectors. And this morning, we're very fortunate to have with us the project lead for QWArS, Mr. Anafi Mataka, and also Dr. Otreda, who are going to talk to us about the QWArS project. So let me start off by introducing our first speaker, our first presenter, Mr. Anafi Mataka, who is the project lead for the QWArS project at ASLM. So Anafi is a project, as I said, is a project lead. He is a diagnostics expert with over 18 years of experience, ranging from frontline health services and frontline health service delivery. Could we kindly ask if everybody can mute? Thank you, Irene, if you could, the administrator to kindly mute. So let me start again. Mr. Anafi Mataka is a project lead at ASLM. He is a diagnostics expert with 18 years of experience ranging from frontline health service delivery as a laboratory scientist to managing national, regional, and international laboratory strengthening programs in limited resource settings. Anafi provides leadership to several projects that include building laboratory and epidemiology workforce capacity for antimicrobial resistance in Africa and Asia, the accelerated adoption and implementation of SARS-CoV-2 antigen rapid diagnostic testing, including community testing for COVID-19, and all ASLM's education activities implemented under the ASLM Academy. So this morning, Anafi is going to provide us in his presentation with an overview of QWArS and the work that we're doing in countries. Over to you, Anafi.
Thank you, Beatrice, for the introduction. Please confirm if you can all hear me.
Yes, we can, Anafi.
Okay. All right. My presentation today, I'm honored to be here to present on the work that we are doing from the ASLM, the African Society for Laboratory Medicine. And I'm going to talk to you on what we have done in trying to qualify the workforce for AMR surveillance in Africa and Asia. As Beatrice has mentioned, this is a program funded under the Fleming Fund. And this is being implemented in, let me see, my slides are not moving. Yes, I hope they are moving now. This is being implemented in 17 countries, 14 of which are in Africa, as you can see, and then 3 of them are in Asia, namely Bangladesh, Cambodia, and Laos. So this emanated from the fact that there is really a current shortage when you look at the numbers and the skills of professionals who are responsible for undertaking quality antimicrobial susceptibility testing, particularly in the labs, including interpreting AMR data. There's also shortage in terms of personnel who are capable of designing relevant and representative AMR surveillance protocols that are required for solid AMR surveillance systems. And we also know that in many of our settings, most of the time, competency standards for AMR surveillance have not been defined quite clearly, even at higher levels, such as reference laboratories. As a result, ASLM, through funding from the Fleming Fund, is leading a consortium of partners in human resources strengthening and capacity building for AMR surveillance through provision of microbiology and epidemiology training for AMR using the One Health approach. And we are targeting all professionals within the human health, animal health, environmental, as well as food sectors. So the consortium partners, namely Africa CDC, and who is giving the stewardship of the project, Institute Pasteur Network, American Society for Microbiology, DTU, the Technical University in Denmark, Foundation Miro, IRISEF, and we have also brought in some subject expert partners, such as the Infectious Disease Institute of in Uganda, as well as the commonly known CLSI. And what are we doing? We are trying to roll out these microbiology and epidemiology trainings across national networks under the One Health approach, as I've mentioned. And we are targeting to get at least two types of levels in terms of expertise. We are targeting to get skilled level, meaning those are the people that are able to perform field and laboratory tasks required to identify and track AMR. And we also need to get some experts who will be able to design and manage systems for AMR surveillance. And we are hoping that at the end of it all, we get that pool of skilled personnel capable of delivering these functions. So as a consortium of partners, we have developed a curriculum which has got 2 tracks, namely the microbiology and the epidemiology, as I've mentioned. The first 2 modules, introduction to AMR and a module on data management, are actually core modules. And then the students will then separate into the 2 tracks where they specialize in microbiology or epidemiology, but not both. As you can see, we also continue after the first 5 modules to do other modules that also increase the expertise for the individuals involved in the trainings. We have also designed a master trainer track. This is really with the goal of making sure that we develop a cadre which is going to be able to create and also deliver educational programs for AMR. So why did we think of developing a framework for AMR experts? Someone might ask, isn't there already training in AMR already happening? So we all know that just like for any other skills and any other sector in particularly in health workforce, even beyond, training is often that very popular intervention to address that shortage of skills. But we also want to mention that training can only be effective if it works towards clear staffing norms, based targets, if it is also deliberately built so that there is country ownership that will comply with standards of quality and and as in the workforce as well as in the education as well. And the training should enable people to demonstrate effectiveness in really developing these skills, in addition to just getting the knowledge. We have also cemented that the fact that the value of training in generating competence to support health programs and providing career benefits to professionals require several conditions that are just beyond mere delivery of certificates of attendance upon completion of either face-to-face or virtual training, which is usually what happens in most cases. We feel we need to go beyond this fact. So what are some of those standards that we think should be relevant? We feel for any training to be effective, it should actually deliver the skills and knowledge required to meet the competence that are there. It should actually deliver validated credentials that are accessed through an unbiased examination for competence and may be regulated within some regulatory bodies within the countries. And it should also embed training into national systems for sustainability. And in the end, we should be able to monitor and evaluate the effect of such training on career development and also human health indicators. In many developed parts of the world, most of the time there are systems that ensure that people qualify within their profession, they get registered initially, and they are licensed upon production of evidence of having maintained some form of competence or getting abreast with current developments. But this is not always present in many of the low and middle income countries. So sometimes for lack of a better word, immature systems, delivering specialty credentials, this is more like a specified skill in a certain area, is actually an entry point that can ensure that critical functions such as surveillance and molecular testing are actually developed as part of a larger system. Hence, we thought of developing the QWArS Qualification Framework. We believe the QWArS Qualification Framework individuals should be selected based on their suitability within their countries. And they undergo a series of modules that I've shared earlier on. At the end of each module, they're actually given a certificate of completion that I have mentioned. And within our framework, completion of all this set of modules is enough for you to get recognition from the Fits Health Consortium CPD program as having completed this course. But we want to go ahead, as I mentioned, to develop a credential which we have called the registered ASLM, skilled AMR surveillance, and either in laboratory or epidemiology professional. So this exam would be written, and then if you qualify, you then have to appear in the register, but you need to maintain these skills through provision of required minimum set of CPD points over a number of years, in addition to maintaining good professional conduct. So what is the value of the registration? We believe it gives some demonstrable evidence that somebody has gained knowledge and skills required to competently perform tasks in microbiology practice and surveillance. The registry also provide that confidence to key stakeholders that there is a level of confidence in the ability of that registered professional to perform certain tasks. And it also acknowledges the registrant's commitment to maintaining that competence through future CPD development. So just rounding off on the blueprint for QWArS, mentioned the One Health approach, that in-service training, the qualification. But for this to be sustainable, we believe we also need to put some measures, hence the master trainer track that is coming through. And we also have the additional component of support through the mentorship program that I will speak to later on in the slides. So having spoken to the blueprint, where are we with what we wanted to do? So I'll just give you some bit of highlights, also mindful of the time for the second presenter. So to begin with, we started QWArS barring, I think, the COVID-19 situation. We started, and the current enrollment is about 352 from 16 countries. The 17th country, Bangladesh, should be enrolling their candidates very soon. As you can see, we have slightly more of the candidates in the laboratory track than the epidemiology track. And we use our ASLM Academy to track progress of these learners. And this is just a screenshot of our learning management system, where candidates actually go through various modules. There's also an interactive forum where people can post their discussions and move on, typically like most of the management systems that you may be aware of. I've mentioned that generally in many of these countries, we tend to have higher numbers of those that are within the microbiology track compared to the epidemiology track. Face-to-face training is being augmented by, is actually augmenting the online training. So one has to undergo the online theoretical based training and prepare them for the more practical face-to-face training that happens. And initially we intended to have these as regional trainings, but then when COVID-19 came, we had to adjust. And then we had to move the training into the countries, which was actually a blessing in disguise. That meant we had the opportunity to increase the number of trainees than we initially intended to do. So we identified subject matter experts within the countries. We conducted formal orientation of these trainees via the module developers. And we also had to procure some of the reagents and supplies that were required for the practicals. This slide just gives a summary of where we are. We are glad to say most of the modules have been completed, particularly the first core modules up to 1 to 5. This is overall across all the countries. And when you want to look across board in terms of the countries, the green means these have been completed. So we are glad that most of the countries are, and a few countries that lagged behind because of various reasons, largely due to the COVID-19 pandemic, which restricted face-to-face trainings, have also tried to catch up. In all this, feedback is very crucial. So we have always tried to get feedback from the trainers, as well as evaluations that we have found very useful. Participants have also given feedback. We realized this is a relatively new program, and we may need to update some of the modules. And one common theme that is coming through is really the more time that may be needed to allocate to practical sessions, just to name but a few. So let me speak roughly to the professional exam. The professional exam is actually a centralized exam that is written, and we have our key partners with extensive experience in delivering and designing professional credentials in the world, namely the American Society for Microbiology and the QWArS group, who have worked with us to standardize the way we do this credential. And it involves development of a question bank, drafting the exams, peer reviewing of the question, validation of the exam itself, and production of the final exam to ensure that there's less ambiguity as possible. The professional exam itself is 110 questions long, and there are multiple choice questions written over 2 hours. And each candidate is actually individually timed by a test administration software after they have signed a non-disclosure agreement at the beginning of the test. And these are some of the images that you see that have been written. So our first professional exam was written this January, late January, and we had 224 eligible candidates at the time, 140 from microbiology, 84 in AP, 185 English speaking, and 39 French. Unfortunately, 22 failed to show up for various reasons. And out of those that eventually sat down, 128 achieved a passing grade, and unfortunately 96 could not match the required standard. This just gives a snapshot of how they were performing. Our pass mark was around 60%, being the minimum level that is professionally designed in such a way that if anyone was going to go into this exam and tried to guess, they would actually fail to get to 60%. Epidemiology also followed the same route. So this exam was relatively challenging, as you can see. A good number could not make the grade. We also tried to just do a deep dive and say maybe language was an issue. The exam was being written in those two languages, one in French and then the other one in English. But as we see, there seems to be a similar trend. Of course, we might need to do maybe another statistical analysis to really validate these differences. But so far, we did not see that significant difference. Of course, the epidemiology track has fewer numbers in the French, hence maybe the graph runs away a bit, but still it follows the same trend. Just to state that on the x-axis is those that were scoring correctly on a certain mark, and then on the y-axis is the percent correct of those that got the question right, and on the x-axis is the question itself. Just interesting to note in some of the groups that I'm personally in, I wish I could be in all the groups, but that's a bit overwhelming. I see interesting comments sometimes. Someone was saying the facilitators were shedding lightning. I don't know whether they couldn't understand what is happening or they were appreciating the training. That was interesting. And obviously some of these slideshows showing people appreciating their outcomes in the exams. We didn't do this. This will seem like everything was going perfectly well, but no. We had to soldier on within the pandemic. Initially planned trainings, like I've said, were converted. But we are glad we actually discovered there's a large pool of subject matter experts that we can count on. We had to postpone some of the modules due to COVID-19 and unrest. We have also realized that I think we have been more skewed towards the animal health than towards the human health than animal health. So we may need to improve on that. As I mentioned, I realized I think the time for the second presenter, I need to make sure that there is enough. What are we doing? There are those people that have passed. There are those that have not made it. But as I mentioned, we would want to do the master trainer track, and we want to support these as much as possible. What you see is a schematic diagram of how we envisage this happening. We want to continue to provide regional mentors to the people that have qualified to be continuously supported in their line of work every day for at least a period of 6 months. And we have our own KPIs that we monitor through the monitoring team that will eventually report to the QWArS team, and hopefully we can make those changes. And as you can see, this platform that we're in, that this community of practice would also be a very fertile ground for such mentorship and interactions to happen. In addition to the master trainer track, we are also working with governments to consolidate what we have gained so far. I think Outrida might give a bit of it in her presentation, and the national task forces for this will be very critical to ensure that we continuously engage together. We are glad that we have moved in Africa, 9 of those 14 countries have actually already created these. 4 are in progress, and 3 are actually 2 are yet to begin. So we realized some countries were lagging behind, so we have scheduled another professional exam. So those people that did not make it in the January exam window still do have another chance, and hopefully we'll have more qualified personnel coming through. I want to thank you for your attention, and I hope you find this also very useful. Thank you, and over.
Thank you very much, Anafi. Just before we move to our next presentation, I would like to remind everybody that we will have a question and answer session after the presentations. So please make sure that you put any questions or comments you have into the chat box, and the facilitators will note them to bring them up to the presenters. So let's move on to our second presentation. And this presentation is going to be a country, to talk about the country experience of the implementation of QWArS. And the presentation is going to be given by Dr. Otrida. So Otrida is an experienced public health expert with over 11 years experience in healthcare and a proven track record in setting up and running laboratories, as well as supporting AMR National Action Plan development and implementation in the Africa region. She spent the first 5 years of her career working in private practice as a research scientist, focusing on diagnosis and management of infectious diseases, before joining the Ministry of Health as an infectious diseases laboratory scientist. Since 2016, she has been working with the Zambia National Public Health Institute, focusing on setting up Zambia's first national public health laboratory network. She is currently serving as head technical manager for the Zambia National Public Health Reference Laboratory and as an AMR national focal point and coordinator. She coordinates NAP implementation and supports with line ministries, regulatory agencies, and civil organizations. She's also served as a subject matter expert for SADC, for WHO Afro, React Africa, Africa CDC, CSC, FIND, and is currently a member of the WHO Strategic and Technical Advisory Group on AMR. So we're very happy to have Otrida Kapona here this morning to talk to us about Zambia's experience of implementing QWArS. Over to you, Otrida.
Thank you so much, Beatrice. Good morning, good afternoon, everyone. Thank you so much for the opportunity to share our experience on this platform. So I will be giving a brief background on our national efforts in addressing strategic objective number 2. Strategic objective number 2 in our national action plan, as well as in the global action plan. Let me just reshare. Apologies, my slides are not moving. Beatrice, is someone able to share for me from your end?
Yes, we can. Please give me a second. Thank
Please.
you. I'm just sharing your slides now, Otrida. Please give me a second. Thank you.
Okay, thank you.
Please go ahead.
Thank you so much. So we can just go to the next slide. Okay, so I will be giving an overview of our national efforts in addressing objective number 2 in our national action plan. So as a country, like most countries in the Africa, in the region and the world at large, we developed a national action plan and drew objectives from the global action plan. And one of the objectives is obviously surveillance and research. Our national action plan provides a coherent framework to addressing AMR in the 4 different sectors, that is environment, agriculture, human health, and animal health, and focuses on awareness, education, surveillance and research, there's infection prevention, issues around sanitation and hygiene, optimization of antimicrobial use, as well as research and development. So on that slide, we can see the 2 pictures. I want to believe that Our National Action Plan is a document that is probably familiar to most of us, but I included one additional document there, which is our integrated surveillance on AMR, a framework on integrated surveillance on antimicrobial resistance that partly guides our efforts in addressing objective number 2. Next slide, please. Beatrice, can you hear me? Thank you. Why is surveillance important in addressing antimicrobial resistance? I summarized this in one word. Surveillance generates data for action. If we're going to talk about addressing AMR, regardless of how we look at it, whether it is raising awareness or optimization of antimicrobial use, we need data to inform our policies and our practice, and that is where that is why surveillance is important. Next slide. Okay, so our efforts. So for the longest time, even before we developed our National Action Plan, we had routine and programmatic AMR surveillance activities in selected labs that were mostly focused on bacterial pathogens. When WHO sent out a call for enrollment into the Global Antimicrobial Resistance Surveillance System, we were one of the first countries to enroll. And at that particular time, we only enrolled one lab because that was the lab that met the criteria at the time. We went ahead and did assessments using the WHO2 as well as the Atlas2, and this was so we can identify the different gaps in the labs and what needed to be addressed for the labs to join the AMR surveillance network and be able to produce representative data, obviously to inform policies. We have had trainings with support from obviously the government, but also our cooperating partners like FAO and WHO. And these have been trainings for our colleagues in the animal health sector, the food sector, as well as the human health. We came up with a flagship program we're calling On-Site Microbiology Mentorship Program. And alongside this, we have another one that we're calling a QMS On-Site Mentorship Program, coordinated through the Zambia National Public Health Institute. And this is for the labs in both the human health and the animal health sector that are in the AMR surveillance network. I'll speak a little more on the on-site microbiology mentorship as I move forward. We have also had some targeted surveillance in the animal health sector, and these have been focused more on antimicrobial use. You will agree with me that when it comes to getting holistic data that we can critically interrogate to inform our policy and our practice, we cannot separate antimicrobial resistance, the profiles we see in the labs, from antimicrobial use and antimicrobial consumption. Next slide, please. So in the animal health sector, there has also been a honey residue monitoring plan that has been implemented, I think, for over a decade now, where we screen those 3 drugs, and this is mostly for honey exports to the EU. We were one of the privileged countries that was a beneficiary to the WHO AGISA support. For those of us that are familiar with this, this was a pilot project that was piloting integrated AMR surveillance that was tracking 3 indicator organisms in the human health, animal health, and in the environment. That was E. coli, Salmonella, and Campylobacter. So this was a very good opportunity for us because it created or provided a basis for us to pilot and then build on how we then roll out our integrated surveillance in the country. For the longest time now, we have been submitting data on antimicrobials used in animals under OLIE. And our Zambian Medicines Regulatory Authority has been conducting post-marketing surveillance and pharmacovigilance There's been collection of import and export data by the Department of Vet Services and ZAMRA. And this is what we're using as a country to approximate our antimicrobial consumption. There's also monitoring and disposal of the drugs, especially antimicrobial drugs, by our Zambia Environmental Management Agency. So there's different institutions and different organizations with a different mandate in the environment, regulation, animal health, human health, coming together to do their part, because we can't begin to separate or put a demarcation when it comes to addressing AMR. It has to be holistic. Next slide, please. So when we were trying to figure out how we structure our integrated AMR surveillance, we realized that because ministries in this country have for the longest time are operated in silos, we have different systems, the labs in, for example, the human health sector and the animal health sector were using different processes, different data management system. We realized it was going to be very difficult for us to integrate the systems from the beginning to the end. And so we had to look at what point do we integrate our surveillance system. So for lab work, we came up with standard SOPs, because obviously microbiology is microbiology, whether in the animal health sector or in the human health sector. And then also we decided to integrate where data management was concerned. And so in collaboration with FIND and with support from FIND, we developed a One Health AMR surveillance data management system, which we launched. This system pulls data from the different data sources that the animal health sector uses. For instance, our animal health sector uses CLab as their data management system. We have DISA in the human health sector, and it's compatible with the district health information system we call DHIS2, and also compatible with WUNET. So it makes pulling data into one place and analysis very easy. Additionally, it also helps us capture our import and export data. And next slide, please. Okay, so these are some of the pictures. They say pictures tell the story better. So these are some of the pictures from some capacity building efforts that we have as a country. Some of the trainings, international trainings, the pictures we see there, are pictures taken when we had our team trained at Kemri. Next slide. Okay, now we come to the on-site microbiology mentorship. So this is a mentorship program designed to build capacity in lab people, except it is being done, we don't take people away from their workplace. We follow them to their workplace, use the materials, resources, infrastructure, and equipment they have on site. So we run them through from media preparation, we have theory, we have practicals. Why are we preparing this media? What media do you need to use for what sample type? How do you do your sample reception? How do you manage your samples? How do you do your cultures? How do you do your IDs? How do you do your purity checks, antimicrobial susceptibility testing, all the way to data analysis? And this is something that we've been doing for almost 3 years now. And we have about 13 labs. So 7 labs in the animal health sector, in the human health sector, and 5 labs in the animal health sector, where these mentorship programs have been going on. You agree with me that building, unlike other tests, building microbiological capacity takes a long time. So we've been mentoring these labs. Every 3 months, we visit them for a period of 2 weeks, run them through the samples that are coming through for routine work, the different processes, until we get them to a point where we are comfortable, like Anafi was saying, and confident that these labs are able to generate quality data, after which we enroll them and they start to contribute to national data that we're using to inform policy and practice, but also submitting to GLAS. Next slide. Next slide. So these are some of the pictures for the mentorship. Next slide, please. Okay, so in addition to the on-site microbiology mentorship, we also have been supporting the labs with improving their infrastructure and equipment, which goes hand in hand with the microbiology mentorships, because if they don't have the equipment and they don't have proper infrastructure, really, we can't begin to talk about AMR surveillance. So through support from the Fleming Fund country grant, we've been able to see some of these labs renovated and supported with reagents, some pieces of equipment that we're missing as well. Next slide. And the next one. Okay, now capacity building for AMR surveillance. So what have we been doing in terms of human resource capacity building? I've already talked about the on-site microbiology mentorship programs that go hand in hand in quality management systems, mentorship programs that are aimed at ensuring institutionalization of quality management systems in this lab, so that we're not just looking at the quantity of the information the labs are generating, but also the quality. We also have been privileged to have had 6 professional fellows trained under the Fleming Fund Professional Fellowship. 2 of them came from human health, 2 animal health, and 2 of them came from ZAMRA, that is a regulatory authority in our country. And the focus for the 2 from ZAMRA was on antimicrobial consumption in the animal health sector, and the other 2 in the human health sector. So this fellowship, we're focusing on lab and surveillance. The other 4, we're focusing on lab and surveillance. And I think for those of us that are familiar with why these fellowships were introduced, was to ensure that as much as the country grants were supporting enhancing data generation, we want to be able to utilize this data, because why are we collecting the data? So there was capacity building for lab fellows, but also those in surveillance, and there was an AP component to it to ensure that when the lab generates the data, we have some people that are looking at this data and they are critically analyzing the data to inform policy and practice. Recently, there were 2 additional fellowships that were introduced called policy fellowships. And these, I think, are meant, the way I look at it is that they are meant to complete the cycle. So we have data being generated, we have data being interrogated, and then data being utilized. That brings me to what Anafi was talking about. So Zambia is one of those countries that has been involved or part of the qualifying workforce development for AMR surveillance. So we started off with about 21 people that were nominated to be a part of this from the human health sector and the animal health sector. And as the time the professional exams were being written, we only had about 15 people remaining in the program. About 15 people remaining in the program. The professional exams were conducted on the 14th of March. Next slide, please. So people fell off along the way for different reasons. I didn't want to go into that, but like I said, by the time we were concluding, we had about 5-6 people leave the program right in the early stages of the program anyway. So what was our selection criteria for choosing who we nominated or we selected to be a part of the program? We were looking at the background, because the focus for this program was lab and AP. So we needed people with that background. Then the current line of work. We were looking at people that were either working in the lab or people that were working or supporting surveillance. And the last most important thing we looked at was the workstation. Were they working at national level? Were they working at provincial level? Were they working at district level or facility level? Because we needed, after all this said and done, for these people to go back and support lab and surveillance in the different provinces, especially at low levels of healthcare. Next slide, please. The mode of trainings, I think Anafi did run through this. They were online modules, they were face-to-face theories per track that were facilitated by the local trainers. We had practical sessions, and I think that, yes, successful completion of all online modules was actually a prerequisite to being able to qualify for subsequent face-to-face trainings. Next slide. So those are some of the pictures from the first one is one of the AP trainings. Then we have one of the practicals for the lab team that was conducted at the Zambia National Public Health Reference Lab. The other picture down there is the final exam. And the last picture was me making sure that their phones were nowhere near them as they were writing their exams. Next slide, please. So ANAPI did refer to the National Task Force. So we're one of those countries that actually went ahead and constituted the National Task Force. And those are the terms of reference for the National Task Force as guided by ASLM. So for us, this was very important, and we felt that even before the training was done, we constitute this task force because the terms of reference for the task force really fits well with some of the things or plans we have as part of implementing our national action plan, because we want to mainstream AMR into the educational curriculum. And so some work has already progressed in this regard. We constituted a national task force. Next slide. With representation from different institutions as guided again by ASLM. So we have human health, animal health, we have academia, both public and private, Health Professions Council of Zambia, because this is the authority in the country responsible for approving curriculum. We have another institution that is responsible for accreditation of the curriculum. We have the Biomedical Society of Zambia, we have the Veterinary Council of Zambia, we have WHO, we have CDC. I'm sure most of us may be aware that CDC has been running in some countries a program called Field Epidemiology and Lab Training Program, which has been successful, and we felt that they would be very instrumental in helping us design what we want to do at national level. Next slide, please. So some successes. So obviously completion of this course, despite the challenges that ANAPI highlighted, COVID and everything else, for us, we feel that it's been a very successful program, and we're very grateful to have had our people trained. So out of the 14 people that sat for the exams under the micro track, sorry, the 7 people, we had 6 people meet the passing mark, which I think is a good thing. From the AP, out of the 7 that sat for the exams, we had 5 of them pass. 2 did not sit for the exam because 1 didn't qualify, and 1 of them was out of the country. Creation of the national task force. So we are currently developing a competence framework and doing a needs assessment. ASLM Academy was kind enough to give us the training modules that they have developed, and we have had a small team within the task force looking at them to ensure that they meet our national regulatory requirements, but also to ensure that it is they address what it is we want to teach for the different categories, whether it's in service or undergraduate programs. We have since identified 3 institutions as pilot sites, 1 public and 2 private universities. Next slide. Like Hanafi said, I don't think there is ever a journey without challenges. So we did have a few challenges. The first one I noted, and these I had to speak and get feedback from the trainee themselves. But the first one was just an observation from our point of view as AMR CC, because the reasons I did indicate that about 5-6 people who had enrolled initially fell out in the initial stages. And for us, this was really due to lack of commitment by individuals. Then the feedback we got from the trainee was that they felt that there was a slight disjoint between the materials in the face-to-face with those on the online modules. Inadequate support from instructors for online modules, maybe was the timings and that there is need for more in-person sessions, elaborating what they learn online for better understanding, limited time. Anafi did allude to this, but then also based on our setting, unstable and inadequate data bundles. Next slide, please. What now? So when I asked one of the trainees, and one of the trainees told me, you and Anafi are the ones who know what's next. So we have incorporated graduates into the national pool of trainers that are supporting with the on-site microbiology mentorships. And then the lab trainee graduates are located in the AMR surveillance sites. So they are working in these labs to generate data, both in the animal health sector and the human health sector. And those that were in the AP track are now supporting disease surveillance, surveillance and disease intelligence units at national and district levels. And they're also working hand in hand with the professional fellows to train others. And we hope, like Anafi said, this can then be incorporated into the pool of regional trainers at some point. Yes, next slide. Okay, there we go. Conclusion. I think you all agree with me that human resource capacity building is critical in building sustainable and resilient healthcare system. That is why for us, capacity building for lab people is very, not just lab people, but everyone in the healthcare system is very, very important and very critical. Like one of the AMR champions in our country likes to say, a country with adequately trained and equitably distributed human resource is a country on its way to sustainable development. Thank you so much for your attention. Thank you.
Thank you very much for that presentation, Otrida. So we can move to our question and answer session. We have a few minutes, and the first question I will direct to Mr. Anafi Mantaka. And there are quite a few questions around this theme, which is very interesting program, great program. How do we get onto the program? How do we enroll for the professional exams? So Anafi, if you could please take that question.
Thanks a lot, Beatrice. Yes, as my colleague here, Otrida, has mentioned, so selection is done at country level. It is the country that initially nominates at present the people that get enrolled in this program. So with this level of interest, I'm actually excited. Otrida is here listening, that there are many more that are interested in getting this. So we are hoping that I think we need to all advocate for this to happen, and enroll as many as we can. But ideally, the countries know better in terms of where they need human resources strengthening, particularly whether it's at national level or at sub-regional level.
Which, sorry, thank you, Anafi, for that. There was another question which was answered by Dr. Pascal in the chat box, but somebody else has asked, so I'll bring the question, read the question and answer, which is, does the exams of next August, so the upcoming exams in August, do they hold the same value as those of February? Yes, so they do.
Very interesting. Yeah. Yes, very interesting question. I think let me also speak to that. They do really hold that similar value because this is a professional credential. Questions will be similar, but they will not be the same. We have another process of developing another question bank. We use what we call scaled scores, and these are more of log values that are put on a certain constant reporting scale. We believe using such scores is a better way of accurately representing that relative performance of exams, and provides that constant reporting across different versions of the exam. So indeed, just to answer that, it's a yes.
Thank you, Anafi. And there was another question, which was, are there any fees for the exams in August? No, that would be a no, Anafi, correct?
No, yeah. As long as you are part of the exam, the program, you have to write the exam for free.
Thank you very much. So the next questions I will direct at Otreda. So Otreda, let me start with a comment from Dr. Alpha Diallo, and he asks, have you approached the University of Zambia to collaborate on certification of this program? That is a question by Dr. Alpha Diallo. Then we'll take another question, please.
Okay, thank you very much, Dr. Alpha. I was actually just responding to him in the chat. So yes, UNZA is represented on the National Task Force and is the one public university where we're going to be piloting this program first. Thank you.
Thank you for that, Otreda. Now, there was a question earlier on which asks from Ethiopia, from Estefanos, and it says, in addition to submitting the AMR data to GLASS, is there any experience regarding AMR data utilization for, say, strengthening guidelines, guidelines for treatment? So what is your experience in Zambia, please, in terms of utilization of this data?
Okay, so like I indicated earlier, for us, submitting data to GLASS is important, but secondary. We want to be able to utilize this data at facility level and at national level to inform revision of our essential medicines list or standard treatment guidelines. And yes, for the facilities that have generated enough representative data, they have already revised their facility antibiotic treatment guidelines. We were just launching last December treatment guidelines for the University Teaching Hospital, and this was informed by their facility antibiogram. So we've already seen facilities begin to use data they are generating locally to inform treatment guidelines, yes. But like I was saying, we are adding more sites, surveillance sites, so we can get a national picture to then inform revision of national treatment guidelines, as well as inform our supply chain and revision of our essential medicines list. Thank you.
Okay, thank you very much for that. There are some comments in the chat box regarding the lag between the online and the face-to-face trainings and how that may have contributed to some of the challenges faced. So participants can read that in the chat box. So there's a question from Bayong Mirabel. I hope I got your name. How will ASLM go about the mentorship of certified QWArS professionals? So Anafi, can I direct that question to you? Is the question is about mentorship of once the professionals have qualified, I believe. Will there be any further mentorship, any other plans, and how will we go about it? Thank you.
Yes, yeah, there will be, as I explained in one of the slides, there is already a mentorship program that is in place where we are trying to link those that have qualified to mentors that can help them in on a regular basis to be more of a backstop to their questions or issues that come up in their day-to-day lives. So some of the mentors will be at country level, some will be at regional level. And we are hoping all those issues that come in would actually be very useful to this community of practice and actually further disseminate that. So it becomes more of mentorship for everyone.
Okay, and finally, we have 1 minute, Anafi. So 2 questions perhaps to answer, and the rest of the questions we will put on the platform, the core platforms, and try and answer those on those platforms. So if you aren't on the platform, ensure that you filled in the registration form and we will include you. But the first question asks why QWArS was extended to Asia instead of incorporating more African countries. And related to that is another question from Edmond, who says, do you have any plans of including the Caribbean region onto QWArS? So over to you, Anafi, for the last minute. Thank you.
Oh, some of the questions are too tough. I may not be able to get you an exact answer, but as you all know, they are just like in many other areas. I think there are certain priority countries depending on where they are for certain conditions. I think for the first phase, I would like to believe these are the first ones that probably needed to get this first. But I would like to believe the ones that were left out were not just deliberately left out for that. And I'm hoping that as we are seeing positive signs for this, maybe this is good impetus for those that could actually have additional funding to make sure that we expand this beyond what we have right now.
Thank you very much, Anafi. So we have represented with us Claudia Parry from Watts McDonald. So she will be in a better position to answer that question. So over to you, Luna.
Hi, thank you. Yeah, very briefly, the reason why there are no other African countries and Asian countries instead is because we started with Fleming Fund priority countries. So the idea, of course, is to start with a cohort of the Fleming Fund priority countries in Asia and do some sort of a pilot in the Asian Fleming Fund countries. But the idea is in the future to cover all the countries, Fleming Fund countries in Asia and Africa. Now for the phase 2, depending of which Fleming Fund countries will be included, we can expand these, and we can also have conversations about including non-Fleming Fund countries in the second phase of QWArS. So it's open to the conversation, but in brief, it's just because we started because of the funding with the Fleming Fund countries.
Thank you very much, Luna, for that clarification. And we look forward to phase 2 and being able to expand this to more countries. So with that, we would like to thank everybody for being present at the sessions. For those of you who are asking whether we will share the presentations, yes, we certainly will. We will share that, we'll make those available to you. Otherwise, thank you very much. If you still have any questions or comments, please, the WhatsApp platform is there. So if you have not joined, please send us your information, put your number in the chat box, and I'll be very happy to add you. We've still got a few places left. And otherwise, please look out for information on our next session at the beginning of April. Thank you very much again. All of you have a good weekend. Have a good day. Thank you.